Okay, so this video is on Plateau syndrome from Jakobiec and Arwind. Not much is given in these books about Plateau syndrome. Few things are given which I'm gonna read. I'm gonna only read because this is audiobook, not explanatory lecture. Epidemiology of Plateau iris configuration angle closure glaucoma. This is from Jakobiec. Epidemiology. Hey! Shh! No! Ouch! Silhouette is very angry because I didn't let him go outside. Okay. Plateau iris configuration angle closure glaucoma from Jakobiec. Epidemiology. A second primary angle closure glaucoma called plateau iris configuration angle closure glaucoma is increasingly being recognized. In this syndrome, the anatomic configuration of the iris is such that the angle closes despite the creation of a patent iridotomy after dilation of the pupil, owing to crowding of peripheral iris tissue in the angle. This occurs despite the absence of peripheral bulging due to RPB. Although the only sure way to ascertain that this is the case is to perform an iridotomy and see if the angle closes whether immediately thereafter or even years later. The distribution of this type of angle closure glaucoma is unknown. This form of glaucoma is uncommon in the United States, but recent reports suggest it is common in East Asians. Symptoms and signs. Patients with plateau iris configuration angle closure glaucoma may present with acute, intermittent, or chronic angle closure glaucoma. Acute or chronic form. The central anterior chambers are generally deeper than in RPB ACG, usually being 4 to 6 corneal thicknesses centrally. The peripheral chamber is shallow, however, and Van Herrick's test is positive, warning the examiner to be careful with dilatation of the pupil. The contour of the iris is different from that in RPB, offering a main differentiating feature. The iris is flatter centrally and then drops off at the periphery somewhat precipitously as it of a plateau. The ultrasonic biomicroscope is useful in demonstrating the anterior positioning of the ciliary processes which push the peripheral iris forward. The appearance sometimes is that of a peripheral roll. Indentation gonioscopy may help in differential diagnosis. After indentation in RPB angle closure glaucoma, the peripheral iris usually hugs the lens and is flattened in the periphery without a peripheral iris roll. In plateau iris configuration angle closure glaucoma, indentation gonioscopy may demonstrate a peripheral roll. If closure exists, it can at first be appositional and later synechial. Treatment. Despite the fact that RPB may not be the major factor in the cause of glaucoma, iridectomy should be performed. This is because we are not often sufficiently known to determining the difference between these two syndromes. Some cases appear to overlap and therefore the pupillary block component should be removed with an iridectomy. If the angle continues to close after this procedure, the diagnosis of plateau iris configuration angle closure glaucoma has been confirmed and further treatment may be necessary. This treatment could be either permanent pharmacologic meiotic therapy or peripheral iridoplasty. Another page from Jakobiec, Plateau iris syndrome. In this anatomic configuration, the iris root angulates forward and then centrally due to anteriorly positioned ciliary processes. This narrows the anterior chamber, causing resistance to aqueous flow. So the page numbers are 2565, chapter 201 from Jakobiec. Now from Arwind, we'll see it's scattered. It's not under a single chapter, but there are some paragraphs from various pages that I'm gonna read only. Plateau iris. In this condition, a large or anteriorly positioned, this is from Arwind now. Plateau iris. In this condition, a large or anteriorly positioned ciliary body pars placenta pushes the iris root mechanically up against the tabular meshwork. The iris root may be short and inserted anteriorly on the ciliary face. The anterior chamber is usually of medium depth and the iris surface is flat or slightly convex. On indentation gonioscopy, the double hump sign is observed even after laser iridotomy. The angle does not open as well as the peripheral iris is prevented from falling back by the ciliary body. Indentation ultrasound biomicroscopy is a spatial technique of examination that imposes mild pressure on the peripheral cornea with the skirt of a plastic eye cup so that one can simulate indentation gonioscopy. Features of plateau iris can be confirmed by performing indentation ultrasound biomicroscopy. Then there is another table. Ultrasound biomicroscopic features in different types of glaucoma, and in that we can see this plateau iris. Ultrasound biomicroscopic findings: large anteriorly positioned ciliary body, peripheral iris roll, iris surface flat, double hump sign with indentation, ultrasound biomicroscopy, one hump over the ciliary body peripheral and central hump over the lens. Clinical significance responsible for failure of LPI, laser peripheral iridotomy. Then another page that is about where, according to the classification, where it stands in the glaucoma. According to the glaucoma classification, it is the type of angle closure glaucoma, and it is the type that is without pupillary block angle closure glaucoma, posterior pushing mechanism. Yeah. So once again, primary angle closure, plateau iris. The development of plateau iris depends on the location of the ciliary processes. Normal eyes have the junction of iris dilator and the ciliary process close to the posterior limit of the drainage angle and thus close to the scleral spur. Plateau iris develops when the ciliary iris ciliary body junction is placed more centripetal and therefore further from the scleral spur. This leads to an anterior attachment of the iris base in which the iris remains closer to the meshwork in a plateau configuration even after iridotomy. About one-third of eyes with narrow angles post-PI have plateau iris. Dynamic gonioscopy reveals a double hump sign where the peripheral iris drapes over the ciliary processes. Plateau iris is more common in younger female patients with a family history of primary angle closure glaucoma, and there is usually some component of pupil block. Cataract extraction cannot reliably widen the drainage angles in eyes with plateau iris as iridociliary opposition still occurs. Argon laser peripheral iridoplasty may be more effective as long-term treatment. Plateau iris syndrome occurs when angle closure with raised intraocular pressure develops despite a patent iridotomy. So, when to call plateau iris configuration and when to call plateau iris syndrome. Plateau iris syndrome when the plateau iris configuration um, has increased IOP and it was treated as angle closure and iridotomy was done, and it's a patent iridotomy, but despite that raised IOP is seen and the plateau iris configuration is seen, then it is called as plateau iris syndrome. The configuration is different, syndrome is different. Syndrome is when the raised IOP along with the patent iridotomy. A study in Singapore using standardized UPM criteria found plateau iris in about a third of PACS eyes after LPI, confirming that non-pupil block mechanisms are important in angle closure in Asians. However, this may not be pertinent to other populations. Plateau iris syndrome. In plateau iris syndrome, the iris remains in contact with the tubercular meshwork despite a patent iridotomy. In such cases, pilocarpine can be used to open the angle and prevent formation of synecdoche. So, that was all about the plateau iris syndrome. from Arwind. In Arwind, it's given on different pages and it is in a scattered form. So I combined Arwind, Shills. In this video, I have combined Arwind and Jakobiec. In previous video, I read it from Shills and I added some videos. You can see that video, and it is a better. That video is a better. It is just supplementary and it is for my revision. And if you have benefited from this, it's good. Thank you so much for listening to me, watching me. Good night.